Hey everybody, welcome back to our next lecture, Introduction to the Integumentary System. This is such a great image, I love it. If you've not ever been to see a Body Worlds exhibit, this is obviously a human, male, holding up all of his skin, our largest organ on our body. It's such a fascinating image here, I think. Honestly, for you A&P folks that are really into this stuff, definitely recommend going to one of these exhibits. It'll blow you away. All right, before we begin, pause the video. Let's start with some practice questions. What do you remember from labs? What about the integumentary system? What are the 5 layers? And what are the cell types you learned about? And do you remember any pathologies? So here's what we're going to do today. We're going to go over the structures and functions of the integumentary system. We're going to talk about the components of the skin, and the skin is made of the epidermis and dermis, and we'll talk about the nuance there. We'll talk about burns and some skin cancer along the way. To start, let's look at the functions of the skin. Let's start really big. What does this thing do for us? First and foremost, it protects us. If you remember from a couple of lectures ago, it's made of stratified squamous, keratinized stratified squamous, so it is got this really nice waterproofing barrier, and it's going to resist abrasion. Melanin, we have melanin inside of our skin. This is what gives us our skin pigment. It's going to help protect us from UV rays. And we also see that it has some kind of immunity function. So we see red blood cells that are kind of hanging out ready to attack any foreign invaders. It's involved in temperature regulation. So we're familiar with sweating, and that evaporation of the water off of our surface cools our bodies down. But we're going to talk a little bit about vasoconstriction and vasodilation. So if you remember, talk about negative feedback, we talked about the effectors, shivering when we're cold and sweating when we're hot. We also regulate and vasoconstrict and vasodilate our blood vessels. So constricting, remember we said last lecture, with smooth muscle in those arteries and those blood vessels. So we can contract that muscle to constrict, and we can relax that smooth muscle to dilate. And that's going to regulate heat loss from our blood and through our skin. And we also have the erector pili muscles, which we'll look at a little bit. Other functions is it helps us with feelings, sensing touch or temperature or pain. It helps us with excretion, and we release various substances through our sweat, so they dissolve in the water and then they're released to our surface. And it helps us with the production of vitamin D, and this is really important when we talk about calcium in bones. Now, if we move into the integumentary system, we're going to start looking at the epidermis. Now, you may remember this model from your labs, but this epidermal layer is the most superficial region. Up here, we can see this little bracket right here, and that's labeled epidermis. So we're going to be talking about this epidermal region right up in here first and seeing what that does for us. Now, we want to talk about some of the cell types that are present in here. So there are 5 key cell types that we're going to be looking at are as follows. So the first cell type that we need to know are keratinocytes. These keratinocytes are the most abundant cells. That I'm moving my pointer over all of these light pink with purple nuclei cells. So if they have a nucleus, they're living keratinocytes. And up here at the top, you can see there's no nuclei, and so those are our dead keratinocytes. And then the skin that sloughs off, those are called exfoliating keratinocytes because they're breaking off and shedding. So they produce keratin, and keratin provides this waterproof barrier to keep water in, and we're going to learn about that stratum granulosum layer that's kind of that barrier between living cells below it and dead cells more superficially. So it's protecting us from the heat, keeping microbes out, keeping chemicals out, keeping water in, So it's really, these cells are really important for us to know about. The melanocytes, we can see, are down here towards the basal region of our epidermis. And so they produce melanin, and that gives us our skin color, but it also absorbs ultraviolet radiation from the sun. So it's trying to protect the DNA inside of all of our cells. Dendritic cells or Langerhans cells, these come from our bone marrow, and they help participate in immune responses. So if your skin is damaged, a little pathogen gets inside of there, these cells can help elicit an immune response. Then we have Merkel cells, and so these are little tactile cells that help in touch sensation, and we'll look at the difference between those and Pacinian corpuscles or Meissner's corpuscles. And then we have stem cells. So here's a little stem cell over here. Now bringing you back to our first lecture on tissues, we talked about totipotent, pluripotent, so those were embryonic stem cells, totipotent from the morula, pluripotent from those inner mass cells of the blastocyst, and then we have multipotent, oligopotent, and then unipotent cells. And so this would be an example of our unipotent stem cell, because this cell is going to divide and only produce new keratinocytes. And as those keratinocytes migrate up, then they eventually get sloughed off. So that stem cell there is not going to make a bone cell or a nervous cell, right? So again, an example of unipotency. One of the things to pay attention to is these dermal papillae. Okay, these dermal papillae are these little wavy ridges between the dermis and the epidermis. So we have this epidermal ridge here, right? And that's going to kind of fit into our dermal papillae. They increase surface area, so you kind of think of papilla as a finger-like projection, and they increase surface area, which helps hold those layers together. We'll see soon that dermis is made of connective tissue, so that basement membrane, that double-sided sticky tape, is going to help hold the epidermis to the dermis, and with the help of extra surface area. It also, that increase in surface area helps with diffusion. So we have more space, so we can have more diffusion from the underlying connective tissue layer, which has blood vessels, into our overlying epidermis, which is made of epithelial tissue with very little matrix and no need for blood vessels. Form and function, don't forget. So here's a nice image with all of these different layers drawn in here and labeled. So down here we can see our dermis. Just above that we see our stratum basale. This blue line would indicate our basement membrane, but we've got our stratum basale, and then we have our stratum spinosum, followed by our stratum granulosum, then lucidum, and then corneum. So make sure that you are able to identify these from superficial, stratum corneum, to deep, stratum basale. So basal portion, basement membrane, basal is at the bottom. All right, now we'll start at the bottom and work our way up superficially. So the stratum basale, again, you can see here numbered 1 with some arrows along the way, kind of elaborating where our basement membrane would be. What does this layer do? It's our deepest layer, a single layer of cuboidal cells, or with a low columnar shape, and they are attached to the basement membrane. Quick question, what are the structures that we learned about that are holding those basal cells to the basement membrane? Those would be hemidesmosomes, holding those down there at the bottom. Those are our anchoring connections. All right, now, there's 2 types of cells that we see in that stratum basale layer, okay? The keratinocytes and melanocytes. All right, now melanocytes are these cells that are in the basale layer that give us our pigment. And over here to your left, you can see this really great image of all the diversity of colorations that our skin has. It's so great, right? So these melanocytes are producing melanin, and those melanin, that melanin is then kind of broken off and endocytosed. Well, first it's exocytosed from the melanocytes in these vesicles, and then it's endocytosed by the keratinocytes that are nearby. And what they do is that they take those little melanin fragments that I'm pointing to with my arrow here, and they orient those melanin fragments on the light side of the nucleus. And when I say light side, I mean, and I'm just going to draw something here really quick, and let's see if we can get it. Oh, yellow, here we go. We're going to draw a really big, bright sun up here that's giving us light and radiation, because that radiation is making its way down, and that radiation is destructive to the DNA in our cells. That can lead to skin cancer. So the melanin is then taken into these keratinocytes. The keratinocytes reorient these melanin fragments and put them on the light side, or the side of the cell that's being exposed to the UV rays, so that it protects the nucleus and the DNA inside. That's super cool. So the other thing that I'd like to point out is that all of us in this class, and all three of my 201 lectures, and all across the world, all have about the same amount of melanocytes. And so you can expect a quiz question about this, or a test question about this. So we all have about the same number of melanocytes. The only thing that's different, right, between this person and this person is the rate of melanin synthesis. All right, some alterations in skin color that we might see. You can see some examples on your screen right now. One is up in the top left is pallor. And pallor is a paleness that can happen from fear, anger, emotional stress. It can also happen during anemia or times of low oxygen. On the bottom left, you can see a hematoma or a bruise. This is when blood vessels are damaged, your capillaries are damaged, and there's sort of an accumulation of blood in the surrounding tissue. In the middle here, you can see a bronzing, and so you kind of get this metallic appearance that can be a result of different diseases or adrenal gland dysfunctions. In the top right, you see jaundice. Jaundice is a yellowing of the skin, and this comes from a buildup of bilirubin. And so our livers process bilirubin, break it down, and that ends up in our urine and feces and cyanosis. But again, this is poorly oxygenated. We get a bluish tint to the skin, where I'm pointing with that. But anyways, we are going to look at a couple of examples of skin cancer. So there's three that we're going to be looking at. Now, over here, you can see here's our epidermis, and here's our dermis. We've got squamous cell carcinoma. So squamous cells should sound familiar with our epithelial tissue. We have basal cell carcinoma. So basal cells, or our stratum basale, and then our melanoma. And so that's going to come from our melanocytes. So if we look over here, we can see our melanocytes, we see our basal cells, and then we see those squamous cells. Okay, so basal cell carcinoma then is a flat, raised, or dome-shaped spot that's kind of pearly or skin-colored. Squamous cell carcinoma is kind of raised and crusty, a little scaly, maybe a little bit of ulceration there. And then last, our melanoma is kind of that abnormal mole that we generally think about changing shape or monitoring. Melanoma, on the other hand, is our least common type of skin cancer, but it's the most serious type of skin cancer. So we often get malignant tumors from the melanocytes. Now, just sort of a side note, for all of you who are like ready to go jump into tanning beds or whatever's going on, maybe the winter's around the corner, spring break's around the corner, you're like, yeah, tanning bed, get on my tan. Keep in mind that the average tanning bulb emits 95% UVA radiation and 5% UVB radiation. UVA, it's great, that's your golden tan, that's what you want. But too much of that UVB, only 5% of the radiation, causes sunburn and can trigger damage to those cells. And it's damaging the DNA because maybe there's not enough melanin to protect the DNA. Now, you don't need to memorize this data, but I wanted to show you some recent data just so that you understand, especially for us, most of us, I should say, living in probably California and Phoenix, we really need to be a little bit more aware of skin cancer. So this is data from the CDC. We've seen that the incident rate of melanoma has doubled in the past 3 years. One person dies of melanoma every hour, every day, right? So about 10% of people have some kind of family history. So generally, it's 90% of people that are too much exposure to sunlight. In 2019, about 96,500 people were diagnosed, right? And that was the number one most diagnosed cancer among 25 to 29-year-olds. So y'all are kind of right around that benchmark, or we'll be there fairly soon. So anyways, keep that in mind. It's good to know. Now, how do we measure this, and how do we check these out when we look at melanomas? Well, we use the ABCDs, okay, ABCDEs. So we look for asymmetry, and we look at two halves of the mole, and are they different from each other? And we can kind of see that they aren't symmetrical over here. We look at the border, and the border is irregular or poorly defined. Then we can look at the color. Is there variation within that mole? And we can look at the diameter. So if it's bigger than a pencil eraser, that kind of causes some concern. And then E is for evolving. And so evolving, it's changing over time. So you may go into a doctor and say, hey, I got this mole, I'm not really sure. And they might say, just keep an eye on it. Let's watch it. And if we see it change, it's a little itchy, it changes color, you probably need to go see your dermatologist again and have them deal with that. All right, next, if we move up, we're talking about our stratum spinosum, which is why we're kind of putting off our squamous cell carcinoma here. So, several layers of keratinocytes thick. They are pushing to the surface. They stop dividing. Our basale layer is where the cells are dividing and pushing up and pushing up and pushing up more cells. And they start to produce more keratin, and those cells start to become less cuboidal and more flat. Now, those cells, if they're damaged from that UVB rays, they damage the DNA, and they can start replicating out of control. So this is the second most common form of skin cancer. It's slow growing, but you can kind of see it's a little bit different, a little bit more crusty than the other kinds. All right, next layer up is our stratum granulosum. Granulum means little grain, and this is only about 3 to 5 layers thick. It's a pretty thin layer of skin, and we see more layers in thick skin than in your thin skin. So like when we say thick skin, I mean on the palms of your hands or on the bottom of your feet versus the skin on your arm or in your elbow. Here, these cells produce lipid-filled vesicles, and so what they are doing now is taking that keratin, and they are starting to release that keratin on top of themselves. So sort of like, it's like they're barfing out keratin onto themselves. And that is waterproofing the cells. It's protecting the more deep layers, forms a barrier between the superficial layers and the deep layers, And once they release that keratin out and on top of themselves, it cuts off nutrient supply to the more superficial layers. So those cells are going to die. And so in this image, you can see that these cells up here do not have those nuclei, where our cells in the lower layers all unnucleated. Okay? And if you remember back a couple lectures ago, I was talking about looking at your cells and trying to identify, are there any nuclei there? But here we don't see any, so we can assume that they're dead. The next layer is called the lucidum. Luci is light, and we only see this in our thick skin, so the feet and the hands. It doesn't stain very well, which is where it gets that name Luci. So if I were to ask you a question on a test, and I said, a nurse is giving you an injection in your elbow or in your cubital region to bring back your body regions, which of the following layers of skin would it not go through? Or name the layers of skin it would go through in order. And so corneum, well, lucidum is not there, so it would go corneum, granulosum, spinosum, basale. Okay, so these cells don't have a nucleus or organelles either, because at this point they're dead, they've been cut off. And then above that, we have our stratum corneum. This is our tough upper layer, and it's real thick comparatively to all of our other layers. So it's up to 30 cells thick, and it renews about every 6 weeks. So the skin you look at right now on the surface of your arm will be new in 6 weeks from now. There's some estimates that you slough off about 1 pound of skin a year. Kind of cool or gross, depending on what you want to think about. If you're a dust mite, that's awesome because you've got a lot to eat. But a lot of even dust in your house, and if you've ever looked into, you're changing your sheets and you see the bed frame and there's a bunch of dust along the metal frame or the wooden frame, that's mostly skin from you. So, and then dandruff is just, surface cells that are flicked off in your hair, and they get kind of clumped together with sebum that you're producing, some of the oil that you're producing. Moving on. Let's talk about the dermis and then the hypodermis. So we've just completed the epidermis analysis, and now we're going to talk about the dermis and the hypodermis. So the dermis is our deeper region of our skin. If we look a little bit more closely, we can see, If we look a little bit more closely, we can see that the dermis is composed of 2 layers, our papillary layer and our reticular layer. We're going to talk about the difference between those. And then down here is that hypodermis. So the papillary layer is made of areolar connective tissue. Great test question. Which of the following tissues is the papillary layer made of? A, B, C, D, E. Okay. In there we see capillaries, we see lymphatic system, we see sensory nerves that are in there to help us feel and sense what's above. And this is where we find our Meissner's corpuscles. So if you remember in labs, those Meissner corpuscles, if you think of the dermal papilla, those little finger-like projections, and I'll just show you over here, so those little finger-like projections right up in here that are increasing surface area, you can think of the Meissner's corpuscles as like your little fingernail that are kind of up into those papillae. And you should be able to see those Meissner's corpuscles right there. To the right of this image, which my face is embedded in areolar connective tissue, get me out of here, just kidding, so remember that image of areolar connective tissue. Again, lots of space for blood vessels, nerves, lymphatics. Okay, great. The dermal papilla then, again, we talked about this before, it's increasing surface area, but it also pushes up into the surface of our epidermis, and this is what gives us our fingerprints, and we can call those friction ridges. If we look really closely at those friction ridges, we also have lots of openings of sweat glands on our fingertips. And so when we grab something, it's that residue that's left over from the sweat glands and the substances that are secreted on those friction ridges that give us that fingerprint. Now the reticular layer is a little deeper to that, and the reticular layer is made of dense, irregular connective tissue. And remember, the function of dense, irregular connective tissue, as you can see down here, is to hold on or to withstand stress in a lot of different directions, so that it's really a nice, it's really capable of holding on to that overlying layers. In there we find lots of glands and hair follicles, blood vessels, lymphatic vessels, nerves, all migrating through this area. And those collagen fibers can give us cleavage and wrinkle lines, which we'll talk about here in a second. And if those fibers are overstretched, maybe during pregnancy or obesity, or you're hitting the gym pretty hard, stacking plates, you get ripped pretty quick, we can get some stretch marks right over here. I guess there they are right by my head. So hopefully you can see those stretch marks on that image there. Cleavage lines then are these lines that surgeons use and are aware of. They'll study these lines that our fibers are kind of running in these orientations. And so if you're aware of these cleavage lines, you can make less scarring during a surgery. So if you're cutting parallel with these cleavage lines, it's likely that you'll have a smaller scar or a reduced scarring. If you go ahead and cut perpendicular to those, you're going to have more scarring. So plastic surgeons that are doing facelifts are really good at understanding the direction of those collagen fibers that are in there, so that they can do this microsurgery. Now, thermoregulation is happening in the dermis. I like to call it the dermis furnace, because it helps us regulate our body temperature. So if it's cold out, we want to minimize the loss of heat. So we can vasoconstrict and reduce the amount of blood flow that's going out to the surface of our skin. So you can see here that blood circulation is being shunted through these capillaries and back into our circulation, and kind of avoiding the skin surface. So we're reducing the amount of heat loss. Here, when it's hot out and we're outside running, trail running around in Flagstaff, we're building up a lot of body heat from our muscles moving. We want to increase the blood flow to our skin surface and allow it to be lost through radiation and convection. And then flexure lines. If you've ever been to a palm reader, this is what they're looking at on the palms, are these flexure lines. Right? And so those kind of help us understand where the collagen fibers are within our tissues. So take a few minutes, review and reinforce, apply some of this information to these questions, and I'll see you in a few minutes. All right, folks, how do we do here? Let's move on, and we'll finish up with the hypodermis. The hypodermis is the lowest layer. You can see down here in our chart, we've got a lot of adipose tissue down here and a lot bigger blood vessels that are going to be running through that hypodermal layer. Now, this is connecting the skin to our muscle, okay? So below the hypodermis would be our muscle tissue. It is composed of adipose and areolar connective tissue. We see that we have our Pacinian corpuscles, so our deep pressure, where Meissner's corpuscles are for lighter sensations. It's an energy reservoir, again, insulation like we talked about with adipocytes. And this is where your hypodermic needles go, or your subcutaneous below the skin injections will go. Now on to a little bit about the appendages that we'll see. Things that exist within our skin. So sweat glands, oil glands, hair and hair follicles, and nails. So if we look here at this diagram, here's this diagram that we've been kind of working through and getting down our layers, our epidermis, our dermis, and then our hypodermis. And we can see some nervous structures in there. So our sensory nerve fibers, so these naked, free-ending fibers that are going to pick up pain and some light touch. We've got our Pacinian corpuscle right over here. We have hair follicle receptors, so we can have sensation from the hair, to and from the hair. And other appendages then are eccrine sweat glands, an erector pili muscle that's going to help stand the hair and give us goosebumps. Our sebaceous glands that we find associated with those hairs, the hair follicle that's surrounding that hair, and then our hair root down here where we can see blood vessels coming in and keeping the lower portion of our hair root alive. So let's go into a little bit more detail about these. Here's just a comparison between our Merkel cell, which we talked about earlier, with these light touch receptors. They are not capsulated, but this is going to bring in sensory information and send that through an afferent pathway. Same with the Meissner's corpuscle, but the Meissner's and the Pacinian corpuscle are encapsulated. So again, you're going to find this. You can see our basal cells here. We're finding this in the top of that dermal papilla. And then our Pacinian corpuscles deeper in that hypodermis. If we look a little bit closer at our glands, I want to talk about 3 different types of secretion that can occur. So the first is merocrine secretions. This is a type of secretion. It's not the chemical coming out, but it's a process of secretion that we're going to be looking at. So if we look at all of these cells, all 3 of the same cells, but if we look at how merocrine secretion works, we can see we've got our Golgi complex in here, and it's producing these little vesicles that are budding off and making their way out to the plasma membrane, and our secretion is being released. So this is going to happen with our eccrine or sweat glands that are going through the ducts. Apocrine secretion, these are our apocrine sweat glands. These are the ones that are generally associated with our axillary and pubic regions where we have body odor. And so what we can see here is, again, we have our Golgi complex making little secretory vesicles, but the cell actually pinches off part of it, or this apical portion of the cell, and this whole part is actually secreted versus just the substance itself. So we actually lose part of the cell and its cellular components, and so as this is broken off, we have more of these organic substances that are released in the sweat. And so when we talk about apocrine glands and bronchidrosis or body odor, there's bacteria that live in your armpits or in your pubic region that when those sweat glands release this type of sweat, those bacteria are eating those organics that are coming out of it. So the next time your roommate tells you, "Hey, you stink, man, you gotta take a shower," you'd be like, "It's not me, it's my bacteria. I'm good." Okay, and the last type of secretion is holocrine secretion. You can see down here. Basically, during holocrine secretion, and this is what happens with our sebaceous glands, we have a cell that starts to produce its secretions, but the entire cell dies and is ruptured and becomes the secretory product. So all of that sebum is released and the cell dies, and we have to regenerate new cells. So it's just a different type of process that depends on how quick we need it. The sebum, losing the entire cell, is more beneficial than where we just need a lot of water to quickly cool our external environment down or cool the surface of the skin down. We don't want to destroy the cells there, so we're just going to release the water. So our different types of sweat glands, we have our eccrine sweat gland, and these have ducts that are going to release the water to the surface of our skin. That water is going to evaporate, and that's going to cool our skin down. And that is then, if you remember, our merocrine secretion. But if we look at our apocrine sweat glands, generally those apocrine sweat glands are associated with a hair follicle as well. So the cells that are producing the sweat way down inside of that gland are rupturing part of it and releasing some of those organics. And then we can see here, I'll show you another image soon, but our flask-shaped sebaceous gland, and those cells are going to release sebum through the hair follicle, through that holocrine secretion. So again, here is a really nice histological view of that sebaceous gland. So here's your hair follicle, and we can kind of see that gland sitting right in there. So in your labs, make sure you're looking for that sebaceous gland attached to your hair follicle. Now, I just wanted to kind of point this out. We all have probably dealt with acne at some point in our life, whether it was on our face or on our back or our arms or wherever it was. And generally what's happening is it's a plugged follicle up here, okay? And so our sebaceous gland is producing sebum, something blocks that, and it builds up, and as it's building up, we can see the bacteria start to proliferate, and as that bacteria build up, they're trying to digest it. We have an immune reaction, and that whole area starts to become inflamed and filled with pus and red. Right? And so we can see that up here with these whiteheads, these little pustules. You can see the hair follicle sticking out of that right there, right? And so when we look at whiteheads or blackheads, right, you're marketed to every day, oh, blackheads, whiteheads, use this cream, use this piece of tape, and use this face mask and get rid of these things. It's just what it is, and they're part of life. But the blackheads are actually oxidized, so that the pus and the buildup actually becomes oxidized, whereas whiteheads are not. So sometimes when you have infants, and this is not a picture of either of my sons, but you can get what's called cradle cap or seborrhea. And basically, it's just a buildup of sebum on the head of the infant. If we look a little closer at the structure of the hair, you've seen this in labs. So we've got our dermal papilla down here at the bottom with our blood capillaries. Remember, we have dermal papilla up here, right, in between the epidermis and the dermis, but we also have that papilla down here around with those blood vessels, okay? We have our hair bulb, that's the actively growing portion of our hair. So this is alive, and so it needs a blood flow, it needs nutrients, and needs to get rid of wastes. We have our root sheath that encloses the hair, forms a bulge at the bottom. This is kind of, there's a bunch of stem cells down there that are going to help with that follicle growth. We have sebaceous glands, as we just went over, and then we have that piloerector muscle that is, or the erector pili muscle, either way it is fine, and that's smooth muscle, so that's involuntary. So let's talk a little bit about nails. Now, I will let you digest this image for a moment. I'll let that sit in while you contemplate all of the questions that are probably going on in your head right now. This is Sridhar Shalal. I'm probably messing up his name, so I apologize for that. He was 66 years old at this time. He set the Guinness Book of World Records for the longest fingernails in 2014. When they measured these, they were 910 centimeters long. In total, so basically each one of those. He never cut his fingernails on his left hand. So these are all made of keratin. We can see that we've got, if we look a little bit closer at some, more normal nails, if you will, or more common nails, maybe that's a better way to say it. It's a scale-like modification, It's really useful for digging or defense, right? It's a good tool. Sometimes you use it to tighten up a screw, but we've got our little nail bed down here, and the root of the nail is under there, and we have these cuticles that kind of cover that up. So some of you go in and get manicures, they push your cuticles back or cut your cuticles. So yeah, this guy though, he actually cut these off after, and these are available for you to see in the Ripley's Believe It or Not Museum, I think in New York. So you can take a trip, maybe after COVID is over or just for fun. But yeah, his hand, his left hand, because he had to hold his nails very carefully so that they never got damaged, he can't use his hand anymore. He has permanent damage because he had to keep his hand like this, and it wasn't like he was, typing away. It's not like some people that have these nails like that are, typing away, and they're good to go, and they can still manage to do everything, which is still amazing to me when I see people with like really long nails. I'm like, how do you do anything? They still figure it out. But he had to, kind of protect this for his entire life. Pretty incredible. So the next thing we're going to go over is burns. And so we are going to classify different types of burns. Now, we use something called the rule of nines. And basically, we can divide our entire body up and assign percentages to this. Now, if we look at this diagram here, the anterior and posterior head and neck is equal to about 9% of our body. So the front half of your head and neck would be 4.5%, the posterior 4.5%, hence 9. If we look at our anterior and posterior upper limbs, so 4.5 on the anterior portion of one limb, so there's 4 of them, that gives us 18%. Our anterior trunk is 18%, our posterior trunk is 18%, so therefore we have about 36%. Perineum region is about 1%, but then our anterior and posterior lower limbs are about 36%. So this adds up to 100% of our body. So now why do we care about that? Well, burns are critical if 25% of your body has second-degree burns, or 10% of your body has third-degree burns, or your face, hands, or feet bear third-degree burns. And the reason is that we are going to lose a lot of fluid because of this burning. Remember, we talked about that, the importance of the keratinized outer layer at the stratum granulosum. It's reducing the amount of water loss, and we're at high risk of infection. So if you look at this person's third-degree burn right here, all kinds of stuff can get in on that. There's going to be a lot of fluid loss through here because we don't have that protective layer. You will need to know this box for your test. I will ask you a question about this. I'll give you a scenario, and you're going to need to determine whether or not that person is in critical condition or not. So first-degree burns, you can see, we've probably all had that living out here in the desert. A lot of reddening, a little bit sore, maybe tender to the touch. Second-degree burns have blistering on them, and then third-degree burns, we're getting deep into that tissue, burned off some of that outer layer. Now, tattoos. Here's some really great examples of some tattoos. Probably a lot of you out there have some tattoos. And that ink is now put into your dermis. Okay? Now remember, why would it be put into your dermis? Hopefully you're saying to yourself, because the epidermis sheds off. And so if I put that ink into my epidermal region, or into the cells of the epidermis, it's going to shed off, which is much like when you talk about a suntan. Eventually, the cells, the keratinocytes that have that melanin, get sloughed off and it goes away, and you lose your suntan because you're shedding off those cells, and you have to continue to go back and kind of tan yourself. So here we've got ink that's placed down into the dermis. It's more permanent, stays there, the dermal cells are stable, and it takes a lot of work to get that out of there. Here's a few more alterations in the skin that we might see. Over in the top left, we can see dermatitis and eczema. Basically an itchiness to the skin, or an inflammation of the skin. Over here to the right, we can see a mole, or a melanocytic nevus. So just another coloration and enlargement on that skin. Down here is cellulitis, bacterial infection, and over here we have cellulitis. So this is herniation of the adipose tissue within that connective tissue, that fibrous connective tissue. And what that does is it creates a little bit of dimpling. I think it's like 85 to 90% of females experience this or have this. It's a totally normal thing. And then last, this brings us to our effects of aging on our integumentary system. And let me make this a little more real for you. This is how I feel every day as I get a little bit older. But what can happen to our skin over time? Remember when we talked about homeostatic imbalances, things break down, which can lead to disease, but we can have less melanocytes, which may cause our skin to be a little more pale and increase our risk for sun exposure. Which, if we're at increased risk of sun exposure, then we're at increased risk of skin cancer. And if we're older, we're probably moving to warmer climates, maybe Phoenix, right? Maybe Tucson, where the likelihood of being exposed to more UVB goes up. So we tend to have thinner and sparse hairs. We lose some of those hairs. We lose the ability to repair our skin, so it can be damaged easier, or it takes a lot longer to heal. I remember when I was younger, you'd get a cut, and the next day, you're like, where was it? And now I'm like, geez, this thing's been there for weeks. It's never going away. So decreased immunity, so our dendritic cells decline, our epidermis thins, we lose our ability to produce vitamin D. As we age, we see a reduced sweat gland activity. So when you think about moving into a warmer environment, and now you're more exposed to UVB rays, but you're also now, you have the tendency to overheat. So if you're living in a hot place, the power goes out, your AC is not working, right? You're less likely or less capable of cooling yourself off, which is probably why when you go to your grandparents' house, you're like, it's like 85 in here, and they're like, feels great. You're like, I'm dying. So they're just kind of used to that heat, and it's okay for them to. The dermis thins out, and we tend to see a little bit of sagging and wrinkling. There's reduced blood supply, so that again contributes to a slower healing and a reduced ability to thermoregulate. Because if you remember, we were talking about vasoconstriction and vasodilation. Again, if we have less blood supply there, we're going to reduce that ability. Our skin gets drier, and so we have less sebaceous gland activity. So we need to kind of keep putting lotion on there, because dry skin can be itchy and slightly problematic. And then we also see changes in the distribution of fat and hair. So our hormone levels change. So we might have more distribution of fat, or we start to see facial hair growth. We've made it. Here we are at the end of our integumentary system lecture. We've made it through all these learning outcomes. Our next lecture is going to be over the skeletal system. I hope you learned something about your integumentary system. I hope you have a new appreciation for it when you look at yourself in the mirror. putting on lotion, go to Papa Zit, or thinking about your body odor when you're at the gym. So have a wonderful afternoon. We'll see you on our next lecture. Thanks for tuning in.